going to give you our certificate as well. Okay, so just stay for that, stay consistent, and tomorrow just follow up. Okay, so let's start with our embryology section. Okay, so the first pathology which your NBME love to test is basically your Truncus arteriosus. Okay, so before discussing Truncus arteriosus, let me just give you a small overview of what's happening, what's a normal process. And you know, pathology, whenever we just discuss a pathology, it's basically an abnormal process. So you need to know the basics first, and right after the basics, we'll be building different pathology, different clinical presentations, different treatment options. Okay, are you guys with me? Hello? Yes, you guys can just turn on your mic. If you guys have any problem, just stop me. We are gonna spend a time on that. Okay, are you guys with me?
Yes. Yes, sir.
Okay, that's perfect. Okay, so
Yes,
remember, okay, once you know our fetus is forming, all of you guys must aware of the fact that we have, first of all, formation of 3 layers. Okay, just give me a second. Okay. Okay, so okay, just give me 1 second. Okay, I think there is some issue in my pencil. Okay. Just give me a second. Let me just fix it first. Okay. Hello, can you guys just see my screen?
Yeah.
Okay, perfect. So let's start our today's discussion. Okay, so as we were discussing, the first pathology which we are going to discuss is Truncus arteriosus, right? So normally, you know, whenever a fetus is forming, it basically we have formation of 3 layers, right? Your ectoderm, your mesoderm, and your endoderm. Okay, and right after that, what happens? Our mesoderm is basically going to, you know, form a structure which is known as notochord. Do you guys know that? Hello. Hello. Okay, just please stay with me. Okay, I need your attention. Okay. So you know that whenever the mesoderm layer just form the notochord, so what happens? Notochord is going to send signals to your. Okay, let me just draw it here. Okay, so these are our 3 layers. Okay, so this is going to be our ectoderm. Then we have our second layer, our mesoderm, and third layer, which is endoderm. Okay, right after that, what happens? There is going to be formation of notochord in our mesodermal layer. Okay, and this notochord is going to send some signals, some genes are going to be activated, and as a result of that, what happens, this ectoderm is going to be transformed into neural plate. Do you guys know that?
Yes.
Hello?
Yes.
Okay,
Yes.
perfect, okay. And once it is transformed into neural plate, what happens, it's going to become like more thickened, and right after that, it would just start invaginating, okay? And it would then in turn lead to formation of your neural tube. And that neural tube is basically responsible for formation of your entire CNS. But once it is invaginating, can you
Sir,
just
you are
please
not
fix?
audible.
Hello? Can you guys hear me now?
Yes, we can hear.
Hello?
Yes, we
Okay.
can.
Okay, please just fix your mic. Please just fix your mic. I'm just seeing some or hearing some disturbances. Okay. So once this neural plate is formed, it would invaginate and information of neural tube. Okay. And as this neural tube is forming, these sides of this plate are going to differentiate into characteristic cells, which are known as neural crest cells. Are you guys aware of that? Neural crest cells. And neural crest cells then is going to migrate into different parts of your bodies, and it's going to mature into different structure. It's going to give rise to a lot of structure. But some of these neural crest cells are also going to come into your beautiful heart, and in the heart, it would lead to formation of a certain structure, which are basically known as, yes, who know the name? Endocardial cushions, right? Endocardial cushions. So whenever you see endocardial cushions, just remember that they're derivatives of your neural crest cells. So let me just draw the structure of your heart. Like, for example, these are the two chambers of your heart, your atria, you have your ventricles, and here lies your neural crest cells or endocardial cushions. Just remember that, right? Okay. Now a question should arise in our mind that what's the function of these endocardial cushions? Remember, as we know that this is your left ventricle, this is your right ventricle, and from the left ventricle basically arises our aorta, right? We already know that. And from the right ventricle, we have pulmonary artery arising, okay? But initially, like this aorta and pulmonary artery used to be a single chamber. Remember that, okay? And like simply, I'll just draw the structure of heart. Like, for example, if this is your heart, so initially or in the primitive stages, both of your vessels, which I'm just mentioning again and again, both of your major vessels, aorta and pulmonary artery, used to be a single chamber, right? And these endocardial cushions are basically responsible for separating them, right? They're important, or they're responsible for separating this chamber into individual aorta and pulmonary artery, right? So the first function of your endocardial cushion that we know are derivative of your neural crest cells, they're gonna form aorticopulmonary septum. Can I say that? Can I name it as aorticopulmonary septum? You guys can see it's basically a septum which lies in these great vessels, which in future is gonna lead to formation of your aorta and pulmonary artery, okay? So these endocardial cushions are going to give rise to your aorticopulmonary septum. Is that clear? Are you guys following me?
Yes, clear.
Perfect.
Yes,
Okay,
clear.
so this is going to be the first function of your endocardial cushions. Okay, then what happens as this septum is formed? We need spiraling of this septum. Why do we need that spiraling? This septum should just get spiral, right? This should get spiral. Why? After the spiraling, then your aorta is gonna come out from your left ventricle. Let me just draw it again. Like, for example, if this is your heart, if you have these great vessels, and once we have spiraling of this septum, so what happens now in future, if we have spiraling process, then you are gonna see aorta that is arising from your left ventricle and pulmonary artery arising from your right ventricle. Okay, so this is going to be your aorta and this is going to be your pulmonary artery. Is that clear? Hello?
Yes, clear.
Okay, perfect. That's perfect. So now we know that neural crest cell in the heart are going to give rise to endocardial cushions. Endocardial cushions is then going to give rise to the septum. And once that septum gets spiral, then we are going to have proper positioning of these great vessels. That is, after the spiraling process, what happens? now aorta is going to get, like, it's going to be coming from your left ventricle, which is the normal position, and now the pulmonary artery is going to be coming from your right ventricle, which is a normal position. So let me, guys, just ask you a question. Let's just focus on this first step. For example, if due to certain reason, if your endocardial cushions or the neural crest cells fails to migrate into your heart, so what do you think? Will this septum be formed? Yes or no? What do you guys think?
No.
No.
No. If we do not have this septum, it would lead to a pathology. It would lead to a pathology. And now we know the nature of that pathology, that a single chamber is going to be rising from both of your ventricles. You have a single vessel arising from both of your ventricles. And the name of this pathology is going to be, who is going to be telling me that? The name?
Truncus arteriosus.
Persistent truncus arteriosus. Okay, persistent truncus arteriosis. Perfect. And this is going to be our topic. Yes, this is going to be our topic, which we'll be discussing in our slides. Okay, but before that, like, I want your concept to be built. Okay, because your USMLE step 1 just focuses on the concept, right? You don't have to memorize anything. Okay, good. That was quite good response. Okay. So for the second step, we discussed that now if we have proper, let's suppose if we have proper migration of our neural crest cells. So the second process was spiraling, right? If we have problems with the spiraling, if the spiraling of this septum do not occur, so we know what would happen now. Your pulmonary artery is going to be rising from your left ventricle, which is normal. And your aorta is going to be arising from your right ventricle, which isn't normal. That is, okay, let me just draw the, draw it here, okay? Like, for example, if we have this chamber, although we have our septum, but it do not spiral. So now what happens? Aorta is going to, okay, this is your interventricular septum, let's say. Now the aorta is going to be arising from your right ventricle, okay? Aorta is going to be arising from your right ventricle, and pulmonary artery is going to be arising from your left ventricle, right? Your left ventricle. And it isn't normal. So what would happen? Now, like, for example, if aorta is arising from your right ventricle, so what happens? We know in the right ventricle, basically, we are going to have deoxygenated blood, right? Am I right?
Yes.
Yes.
Sir.
So now what happens?
Yes,
the deoxygenated blood is going to go into the aorta, into your systemic circulation like that. And again, it is going to return back into your heart. So you guys can see you have a circuit forming here, right? Can you guys just follow my lines?
Yes.
Perfect. And for example, if your pulmonary artery is arising from your left ventricle, so the oxygenated blood is going to go into your pulmonary artery. And okay, so these were your systemic circulation. And we know pulmonary artery leads to your lungs, right? Hello?
Yes.
Okay. So what happens now? The blood would enter into your pulmonary artery, into your lungs, and back into your left side. So you guys can see we have two individual circuits being formed, right? And it isn't good. So, for example, if a baby is having this condition, so my question for you guys is that if I'm just oxygenating him, like, he'll be cyanosed, right? After birth, he'll be having cyanosis. The reason is quite clear. Why? Because the deoxygenated blood is moving in his systemic circulation, returning back, and they have formed a circuit, right? So if I'm just administering 100% oxygen, so still the condition won't improve. Very high yield, you'll just get a UL MCQ on that, and we only love to test this concept. If we have a baby, he comes to clinic, he's cyanosed. After administration of 100% oxygen, his, his symptoms aren't improving. Just think of it's basically a condition. Okay, what's the name of this condition, by the way?
TG.
Transposition of great vessels.
Perfect. Transposition of great vessels. Transposed. They are like, they are switched. They have switched their locations, right? So if we are just administering 100% oxygen, so now we are oxygenating this pathway. We are further oxygenating this pathway. And it won't provide any help because we want oxygenation here in your systemic circulation, right? So for that, what should be your initial step of management? Very high yield, one of your UL MCQ. What do you guys think?
Keep the ductus arteriosus open.
Perfect.
Keep both belonging.
Keep the shunts open, right? Perfect. Is that right?
Yes.
Okay. So let's just refer to our slides, okay? So I'll be just reading these slides. I have just marked some of MBME style MCQs and you guys are going to answer me that, okay? So truncus arteriosus. We already know that truncus arteriosus here, like you guys can see, okay? Okay. So the normal physiology, we know that neural crest cells are going to migrate. They are going to form like your, okay. Okay. So what happens that normally your neural crest cells are going to form your endocardial cushions, and right after that, what endocardial cushion is going to give rise to? It's going to give rise to your septum, right? And after this septum formation, we are going to have spiraling, right? So if the septum at first do not form, it's going to end in a condition persistent truncus arteriosus. That is a single vessel arising from both of your ventricles, right? So okay, it's also associated with DiGeorge syndrome. Can anyone just tell me something about DiGeorge syndrome? Have you guys ever heard this term?
Failure of sudden fourth pharyngeal pouch to
21q11
Two
defect.
Perfect. 21q11 gene mutation. So what would happen as a result of that? We have failure of third and fourth pharyngeal pouches to form. If the third and fourth pharyngeal pouches fails to form, we are going to have some problems. Remember that. First of all, we'll see some facial defects in this individual. Why? Because third and fourth pharyngeal pouch helps in formation of your facial promises, okay? Secondly, you'll be having problems with some heart defects, with some great heart vessels defect. Why? Again, third and fourth pharyngeal pouch helps in formation of your blood vessels. And the most common pathology which we are going to see is persistent truncus arteriosus. The second most common pathology associated with DiGeorge syndrome is going to be your, yes, TOF. What is TOF? Tetralogy of Fallot, okay? Okay. An important thing which you guys know that we are also going to see thymic aplasia, right? No thymus. Thymic aplasia, right? So we'll be discussing in our immunology sections and our marathon. So we'll be discussing in detail, but let me just give you an overview. Thymus is basically responsible for maturation of your T cells, right? So there are basically two processes going on within the thymus, that is positive selection and negative selection. Once we have that, our T cells are going to become mature. So if we have DiGeorge syndrome is basically associated with thymic aplasia, right? And if we have thymic aplasia, it means there will be, some autoimmune diseases. Why? Because the T cells will fail in participating in negative selection, which is important for your, tolerance. We'll be discussing the central and peripheral tolerance in detail, okay, in our immunology section. Perfect. So we discussed that in DiGeorge syndrome, we are also going to see some defect of the great vessels of your heart, right? Great vessels of your heart. That's very important. So let me just go back into my slides. So as we discussed that DiGeorge syndrome is also related with your transposition or persistent truncus arteriosus. So here you guys can see the picture. Here you guys can see a single vessel arising from both of your ventricle due to failure of the septum form. And we know how do the septum develop? From your endocardial cushion, which are basically your neural crest cell. You guys can see the picture here and everything is going to be clear. Okay. Then we have transposition of great vessels. We already discussed in detail. Once we have that septum needs to become spiral in order for the proper location of your aorta and pulmonary artery. If we have failure of spiraling of your aorticopulmonary septum, what happens now? We are going to have two parallel circuits. I just showed you the two parallel circuits, right? That is, aorta is going to be arising from your right ventricle, and from the left ventricle, we are going to see pulmonary arteries, okay? And a very important point which you guys should just keep in mind, that a diabetic mother having a child, basically they are like more prone to have this condition, okay? So it's basically, associated with mother with diabetes. Very high yield, just note that down. You guys are gonna see that in your future, in either your NBMEs or in your G1, right? So, as we discuss some of the clinical features of transposition of great vessels, we discussed in detail. As we have two different circuits, right? And we do not have intermixing of the blood, right? We need that intermixing of blood. Let me just refer back to this slide. If we have these two circuits, and if we want oxygenated blood to be here in systemic circulation, we need the shunts to be open, right? We need the shunts to be open. That is going to be your first line of management. We have a UWorld MCQ on that as well, okay? We need shunt to be open. Just keep that in mind. You are definitely going to see MCQ on your NBMEs, okay? So what happens that in this case, like if we just administer 100% oxygen, it's not going to improve the cyanosis. We already know that. Why? Because basically you are, like further saturating your oxygenated blood, which won't provide any help, right? So if the intermixing happens by any chance due to opening of these shunts, if the oxygenated blood is moving into this like circuit number 1, I would say, right? So now you can have oxygenated blood and the cyanosis can be improved. Very high yield, just keep that in mind, okay? So let me just refer to our slides again. So on the chest X-ray, basically, we are going to have like a characteristic structure that is egg on string. Keep that in mind, okay? So let me just give you a little bit concept about that, okay? So once we have spiraling of your aorticopulmonary septum, if it's your heart, and now we are going to have like aorta arising from your left ventricle, pulmonary artery arising from your right ventricle, for example, if this is your septum, okay? So you guys can see that now the mediastinum is covered by both of these. After the spiraling, what happens? The mediastinum, like you are going to have a proper, like area for both of these vessels. If these vessels fails to spiral, now we are going to have a single vessel arising, okay? If they fail to spiral, we are going to have like aorta arising from your right ventricle, okay, and pulmonary artery arising from your left ventricle. And in that case, now it would be occupying less area of your mediastinum. So the mediastinum is going to appear like narrow, okay? And the heart would just appear as you have a narrow mediastinum with the heart. So you can just resemble it as egg on string appearance. So this narrow mediastinum and these vessels are basically referring towards the string, and egg basically referring towards your heart, okay? So egg on string appearance, very high yield. Just keep that in mind. If you have that in mind, you can just easily solve any, like you can just at least get a clue of what pathology is basically your UWorld or NBME discussing, okay? So as we discussed hyperoxia test, if you just administer 100% oxygen, condition won't improve. So if you have an MCQ, we have a baby, he is cyanosed, and we are administering 100% oxygen, the condition isn't improving, just click in your brain, yes, they're talking about transposition of blood vessels. If they're just giving you on X-ray, we see egg on string, just think of transposition of blood vessels, okay? So what would be the initial management? As we discussed, keep the shunt open, right? So keep the shunt open, or either, okay, what are the shunts, normal shunts? As we know, one is your patent foramen ovale, right? Foramen ovale. So just, increase the size of foramen ovale. It would just let more blood to enter from left circulation into right circulation, which is going to improve your condition, okay? So it is like we are facilitating the shunt. We are keeping the shunt more open in order to have proper oxygenated blood mixing within the circuit number 1. Just keep that in mind. Another thing, keep the patent ductus arteriosus open. You know what is ductus arteriosus? Yes, anyone? It's a connection between two vessels. Just, I want you guys to be telling me that.
Parts of aorta and
Left part of the
pulmonary
pulmonary
artery.
artery and aorta.
Perfect. Okay, which part of aorta? Ascending or descending aorta? Very high yield. Descending aorta. Perfect. That's perfect. Keep that in mind. Okay. So if we are keeping the ductus arteriosus open, again, now we are having chance. Okay, let me just show you here in this illustration which I have made. Okay. So as we know that this is your aorta, and just give me a second. As we know that this is our aorta and pulmonary artery. So ductus arteriosus is going to be connection between them, right? If you are keeping open the connection, now again your oxygenated blood can enter into your circuit number 1, and it can improve the cyanosis. Is that clear? So this is going to be your first line of management for this condition. Okay. So, okay. So you guys can see here transposition of blood vessels. In this case, you guys can see the right ventricle is giving rise to your aorta, while your pulmonary artery is arising from your left ventricle. Why? What's the main cause of this pathology? Failure of spiraling of your aorticopulmonary septum, which arises from endocardial cushions. Endocardial cushion itself arises from neural crystal. We already know that, okay? I'm just repeating things again and again. Okay. So this is one of your NBME style MCQ, right? So let me just give you a clue if you have any like an MCQ, how to read that first, okay? So you guys like must start from the last 3 lines, okay? First, it's going to give you a clue that basically this MCQ is going to refer towards which pathology, okay? So I want you guys to just answer me this MCQ. So let me just select someone for this MCQ. Those who want to just answer this MCQ, please raise their hands. I'm going to select. Okay. Dr. Roni. Dr. Roni, can you just please turn on your mic? Dr. Roni? Dr. Tamanna?
Yes.
Can you just, okay, perfect. So can you just please read
Sorry,
this MCQ for your
I
minutes?
can't. Yeah. Now I can see your screen now.
Sure, sure.
Okay. Shall I read it?
Yes, just read. And I've
Okay.
just given you the clue. Just whenever you get MCQ on your UWorld or on your real exam, just try to read the last 3 to 4 lines, because like most of the things lies in your last 3 to, it will just save a lot of time for you sometime, okay? Yes.
Okay. Which of the following temporary intervention is most likely to improve this newborn's oxygenation status until definitive surgical repair is performed? Obviously, it should be PDA. We should give open the PDA.
Okay, let's read the entire MCQ, okay? Let me just read that for you. A full-term newborn present in delivery room with mild tachypnea and cyanosis immediately after the birth. Keep that in mind, immediately after the birth. Prenatal ultrasound reveals transposition of great arteries. Already they just told us the pathology, right? So if you know the pathology, what they are asking you that which of the following temporary intervention is most likely to improve the newborn oxygenation status until definitive surgical repair. So before looking to the answer, okay, they are basically asking, we have transposition of great arteries. What do you think would be the initial step of management? We discussed that.
Keeping the shunts open.
Keep the shunt open, right? Or facilitate the shunts. So what do you think, what should be your answer?
D.
Creating a larger communication between atria.
That's perfect. Creating larger communication between atria, because there lies foramen ovale. And I just told you, you have to keep, so you have to facilitate the shunt, just enlarge that portion, okay? Just enlarge the cavity size of your foramen ovale, so it's going to help with your oxygenation, okay? So the next MCQ, who is going to read this for us, okay? Okay, just give me a second. We were discussing our next MCQ, okay? Hello? Okay, who is going to discuss our next MCQ? Please raise your hands. Doctor. Okay. Dr. Umar. Dr. Umar, can you just please turn on your mic? That's perfect, okay?
Yes.
Okay, so this is going to be an MCQ for Dr. Umar. He is going to read it for us, and he is going to try to, look for the answer. Yes.
Okay, today old boy is being evaluated in the nursery for irritability.
Okay,
He was
okay. Sorry for interrupting. As I told you, if you are just doing your USMLE step 1, just write it down. First of all, you have to read MCQ last 4 lines or 3 lines of your MCQ, because it's going to say, okay, this is the pattern which you guys have to be following, okay? Yes.
Okay. An echocardiogram shows the origin of the aorta lying anterior to and to the right of the pulmonary artery. Failure of which of the following processes during embryonic development is most likely responsible for this patient's findings on image?
Yes, now you can just read the entire MCQ.
Yes,
2-day
fusion.
Yes.
Yes, it's
No,
fusion.
just read the, once you read last 3 last 3 sentences, then just read the MCQ from beginning.
Time. A 2-day-old boy is being evaluated in the nursery for irritability. He was born to a 22-year-old prima gravida who received limited parental care. Delivery was incomplete, and Apgar score were 7 and 8 at 1 and 5 minutes respectively. Temperature is 36.7. Blood pressure is 70/30. Pulse is 148 per minute. Respiration was 68. On physical examination, the patient is cyanotic and irritable. Cardiac auscultation reveals no murmurs. Serum lactate level is elevated.
Okay, serum lactate level is elevated. It means that
Yeah.
this boy again is cynosed, right? He's having cyanosis. And as the last three sentences already just told us, we are having a condition that is, yes, transposition of great vessels. So what do you think, which, as we already discussed, okay, this is the exact keyword MCQ, by the way.
Yes, it's the spiraling. Answer number 8.
That's perfect, spiraling, right? Okay, so let's discuss our next topic, that is atrial septation. Very high yield. Before discussing our atrial septation, again, I'll just refer to my notes and I'll just give you the concept, and everything is going to be like quite easy for you, right? Atrial septation, as the name indicate what is, okay, just give me a second. We have atrial septation. So as the name indicate that in between our atria, we have septum. How does that septum develop? That is going to be our topic for today. That is atrial septation, right? So for example, if this is your heart, okay, so these are your atria, and these are, let's suppose, your ventricles. So in between atrial septum, in between your atria, you have septum, and in between your ventricles, you also have a septum. This is basically known as interatrial septum, and this is your interventricular septum, okay? So how do the septum develop? Remember, okay? So we'll be discussing that. Okay. So let me draw the embryological stages, how the septum is getting developed. So we know that we have endocardial cushions present here, right? You know, endocardial cushion arises from your neural crest cells. We know that, okay? So, and first of all, what happens, you're going to have formation of your primitive septum, okay? Like a first septum which develops. So let me just name the first septum as septum primum. What do I mean by septum primum? It's the first septum which is going to be developed during this embryological process, right? So septum primum would develop. It would just approach your endocardial cushion. But as they're approaching an endocardial cushion, it would just stop at a certain point. Remember that. I'm just making a story for you guys so that everything is quite easy for you. So this is the first septum. Let me just name it as septum primum. It would approach your endocardial cushion, but it would stop in the middle. And as it stops, you guys can see now we have a foramen here, right? An opening. It's the first opening. So let me just name it as foramen primum, right? Right? Can I name it?
Yes.
Perfect. Now what happens? It would just approach your endocardial cushion. But as it approaches endocardial cushion, apoptosis would happen here, right? In this septum. Like this part of the septum is gonna undergo apoptosis. As it undergo apoptosis, again, now we have formation of a foramen here, right? After apoptosis, you guys can see here is a foramen built, right? Hello?
Yes.
Perfect. So it's the second foramen which we are discussing. So let me just name it as foramen secundum, right? Can I name it as foramen secundum? Okay, perfect, right? Remember that the first wall, septum primum, is like very flexible. Can you just please fix your mic? There's some disturbance, please. Okay, perfect, okay? So remember, the septum primum is flexible. Dr. Jamil, can you just please fix your mic? Thank you so much for cooperation. So it's like quite flexible in nature. Remember that. I'll be just telling you the significance. Why am I just telling you that it's flexible? Dr. Jamil, okay, can you just please fix your mic? Okay. So now we have septum secundum as we discussed. Now we are going to have formation of another septum, right? Second septum here, right? But this time, this septum would start arising from both of the poles, both the upper aspect and the lower aspect endocardial cushion. So the septum, can you just please fix your mic, please? Okay. So for the septum primum, we were discussing that septum primum basically arises from the superior pole, and it's just moving towards your inferior pole, towards your endocardial cushion. But for the second septum, which is going to be your septum secundum, obviously, right? It's going to start building growth from your superior and inferior pole. Okay. I'm just experiencing some disturbance in your mic. Can you just please fix your mic? Okay, let me just mute. Thank you so much. Okay, so the septum secundum is going to be formed. Remember, septum secundum is basically, hard in nature. It isn't flexible, okay? And for the septum secundum, we discussed it's going to approach from both the poles, both the superior and inferior pole, right? And it would just approach towards one another, and it would just form a foramen here as well. So remember, this, okay. So
Dr.
right
Howard,
after the
someone is distracting Dr. Howard, please.
who is just distracting? Please fix your mic. It's a request, please. Okay, so here you guys can see that we have septum secundum. Okay, septum secundum is hard in nature. We know that at birth, basically all of your pulmonary vessels are constricted, right? If pulmonary vessels are constricted, it means that the resistance is very high. Again, I'm just hearing some disturbance. That's what's the problem. Please fix that. I don't want to mute you guys because I want to have an active discussion here. So please just, be humble and fix your mic, okay?
Excuse me, Doc.
Yes, please.
Doc, I have a question. As I don't hear you properly at that time. Like septum secundum, how is it formed?
Okay.
I didn't get that point. How it formed.
Okay. Okay. So septum secundum basically is the second septum which is going to arise during your embryological process. But for septum primum, we were discussing that it only arises from the superior pole. It's going to move down. It's going to join with your endocardial cushion, right? But for the septum secundum, it's going to start developing from both superior and inferior aspect, and they will just try to meet one another. Are you clear now?
Yes, Doc. Thank you very much.
Okay, perfect. So as we discussed that at birth, basically all of your lungs are collapsed, right? Your lungs are collapsed. So as the lungs are collapsed, it means that the resistance is very high in your lungs, right? If the resistance is very high in your lungs, it means that, let me just draw the structure of your heart. For example, if this is your heart, this is your pulmonary artery, this is your aorta, let's suppose, and you have lungs here. So before birth, all of your, the baby do not breathe. We know that if he do not breathe, we have hypoxia, and hypoxia lead to vasoconstriction. We'll be discussing that in detail in our future lectures, okay? So as a result of that, what happens? The pulmonary resistance is going to be very high. If the pulmonary resistance is going to be high, it means that the pressure at the right side is more as compared to pressure at your left side before birth. But right after the birth, what happens? Your lungs are going to be opened. Once the lungs are opened, the resistance is going to drop down. And once the resistance is dropped down, the blood is going to enter into your lungs. Now the left-sided pressure would be high as compared to the right-sided pressure after the birth, right? Because the left-sided pressure is high. Why? Because we need the left side, we need left ventricle to perfuse our entire circulation, to perfuse our entire body. So for that purposes, the left-sided circulation is high in pressure, okay? So after the birth, what would happen? The left-sided pressure increases. And as the left-sided pressure increases, it would just push this flexible septum primum against your hard septum secundum due to increased pressure. As it is pushed against, as the septum primum is pushed against your septum secundum, with time, it would undergo fibrosis, and ultimately this foramen, which is your foramen ovale, it would close. The shunt would close. But if we have failure of closure of foramen ovale, it's going to lead to a lot of problems, which we are going to be discussing in our slide, okay? So let me refer to the slide. So as we discussed, what's going to be your first step? The first step is septum primum formation. Okay, so form inferiorly from superior primitive atrium. We discussed it's going to arise from the superior aspect of your primitive atrium. And it would just, first of all, come, it would stop in the middle, it would just lead to formation of septum primum, right? Septum primum. okay, or ostium primum. The second step is foramen and septum secundum formation. So septum secundum would form just at like the right aspect of your septum primum, and as we have after the birth, the left ventricle pressure or the left side pressure increases, foramen ovale is going to be closed, right? This is going to be your normal process. So let me just tell you, as we discussed, if you have failure of closure of the foramen ovale, it's going to lead to a lot of problem. That is patent foramen ovale. Patent foramen ovale or open foramen ovale. If we have open foramen ovale, it would lead to a lot of problems. Let's just discuss that, okay? Okay, I think, okay, whose mic is that? Okay,
So please, this is distracting everyone.
no problem. Distraction ended, okay? Hello? Hello?
Yes.
Okay, perfect. Okay, so
Thank
we
you.
were discussing that, for example, if this is your heart, your atria, in between your atria, okay, this is your interventricular septum, for example. If we have, okay, let me just separate both of these vessels. Okay, these are your atria and these are your ventricles. Okay, atria and ventricles, you guys already know that. So normally this foramen have to close, but if this foramen do not closes, there is going to be a lot of problems. What problems can we see? Really important. Okay, first of all, for example, if you have an individual, he's having a deep vein thrombus, right? Deep vein thrombus. Like we'll be discussing deep vein thrombosis in our hematology section. We'll be discussing our Virchow triad, what leads to your deep vein thrombosis, and things like that. So if those who want to attend the lectures, so they can just join our 120 days marathon. So we'll be discussing each and everything in detail. Okay. So for example, if you have a thrombus in deep vein, so sometimes what happens, this thrombus can get embolized, right? And once this thrombus embolized, what happens, we know that all of your deoxygenated, okay, these are veins, and veins drain into your right-sided heart, right? So sometimes what happens, this thrombus can also get into your right side, okay? This can also get into your right side. Let's discuss a normal individual first, then we'll be discussing patent foramen ovale, individual with patent. In a normal person we discuss, we won't be having this opening, right? So if a normal person develop DVT, deep vein thrombus, and if the thrombus dislodges, it would enter the right side, and from the right side it would just enter the left. I don't know what's the problem. Whose mic is that?
I have an idea. You can just add me as a co-host, and then I'll just mute them every time they speak. So you can keep explaining things if you want.
Yes. Okay. I'm just adding some co-hosts. So though, if someone is disturbing this, please remove that from the meet. Okay. Okay. If you have disturbance, I've just made multiple co-hosts, so please remove them from today's workshop. Okay. Thank you so much. So for the normal individual, okay, let me just do it again. Okay. So we were discussing, like, for example, if you have a normal individual with normal heart, we have his atria, proper septums between the atria as well. He do not have any patency of his foramen ovale. Let's suppose if this individual develops deep vein thrombus, we discussed that this thrombus can dislodge. It can become emboli. What is emboli? It's basically a moving thrombus, right? So this emboli would just enter into your right atrium first, and from the right atrium, it can enter your right ventricle. From the right ventricle, we know that our pulmonary artery arises, right? And pulmonary artery leads to your lungs. So in normal individual, if we have this case, if we have DVT, deep vein thrombus, it can just dislodge, it can become an emboli, and it would just follow the path of blood. It would enter your right ventricle, and from the right ventricle, it would just enter your pulmonary artery into your lungs. And once it dislodges in the lung, it would lead to a condition which is known as pulmonary embolism. We'll be discussing pulmonary embolism in detail in our hematology section, right? It was for a normal individual. Are you guys getting me?
Yes, sir.
Yes, sir.
Perfect.
Yes.
Okay, let's discuss an individual with patent foramen ovale, right? So for example, if this is his heart, an individual with having like a patent foramen ovale, if he has an opening here, right? So what happens again with the same condition, DVT, let's suppose the thrombus dislodges. So this thrombus would just enter your right atria as we discussed. And in this individual, as we are having this path, right? As we are having this pathway. So what happens, this thrombus can enter directly from your right atrium into your left atrium. And once it go into your left atrium, from the left atrium, it can enter into your left ventricle, into your aorta, and it can enter your aorta. As the thrombus enter aorta, it can cause a lot of problems. Either the thrombus can enter your mesenteric arteries, giving you like bowel ischemia. It can enter your renal arteries, giving you renal artery ischemias or renal necrosis, right? It can again enter into your cerebral arteries as well. We'll be discussing each and everything in every module, right? The arterial systems and everything. So it can enter your systemic circulation and it can cause a lot of problems. Does that make sense?
Yes, sir.
Hello? Okay, so we discussed for normal individual, it isn't possible for this thrombus to enter from the right side to the left side for a normal individual, right? In a normal individual, it would just cause pulmonary embolism. It can never enter your left side, but an individual with patent foramen ovale can have, probability of this thrombus, the right sided thrombus can enter the left sided circulation, and it can cause a lot of problems as we discussed. Let me just mention them. It can cause it can enter your CNS, it can cause stroke, it can, this embolus can, lodge in your renal arteries, it can cause renal necrosis, it can, go into your celiac trunk, it can go into your superior mesenteric artery, it can give you your bowel ischemia, right? So what is this emboli called? Whenever the embolus enters from the right-sided circulation to the left-sided circulation, and that's only possible if we have patent foramen ovale. This type of embola is basically known as paradoxical emboli. Just keep that in mind. What's it called? Paradoxical emboli. Let me just repeat it again. Whenever the right-sided thrombus, whenever a DVT thrombus moves from the right-sided circulation to the left-sided circulation, it can only occur if we have patent foramen ovale, right? Whenever it enters, it's basically called as paradoxical emboli. So one thing keep in mind, paradoxical emboli is most probably going to be seen in patent foramen ovale. Okay, so let's discuss our slides now. Okay, so before discussing that, let's discuss one of our NBME MCQ. So who want to participate in solving this MCQ? Please raise your hands. Okay, Dr. Ronnie, can you just please turn on your mic? Okay. Dr. Bhavani. Dr. Bhavani, can you, okay, Dr. AU, yes, thank you so much, Dr. Bhavani. Okay, can you just please participate in this MCQ? Can you just please answer this MCQ? Just read it for our students and then try to answer this MCQ.
During ECG, agitated normal saline is injected into peripheral vein and bubbles are seen passing into the left side of the heart. Which of the following is the most likely cause of the observed finding in this patient?
Okay, perfect. Okay, before discussing this MCQ, when do we use bubble study and what is bubble study? Let's discuss that, okay?
Yes, sir.
Hello? Okay.
It is kind of agitation saline with the blood of the patient.
Okay, perfect. So
And,
remember, the bubble study is like used to detect whether an individual is having patent foramen ovale or not. Okay, so let me just draw the structure. Okay, so for example, if this is your heart, right? Like this is a heart of an individual having patent foramen ovale, right? So we know that patent foramen ovale is basically, a communication or a septal defect. So what we are, how to, check whether if individual is having patent foramen ovale, yes or no. We are going to do bubble study, right? So what is bubble study? We are going to inject like agitated normal saline. And as this normal saline, it will just form, it will just come here, it will just form some bubbles. And on imaging, if you are just seeing some bubbles here in your left atrium, it would indicate that yes, we have patent foramen ovale. You will clearly see bubbles on imaging after administration of your agitated normal saline. Okay, that was a clue. Let's just read the, okay, Dr. Bhavani, can you just please proceed with the MCQ?
As per
sorry.
you said,
Mm-hmm.
as per you explained that the bubble saline will, if the bubble saline is shown in left atrium, then it's the case of patent foramen ovale. So in this case, it is the incomplete fusion of atrial septum primum and secundum. Answer is
That's
D.
perfect. That's perfect. Okay, so this is exact MCQ of your due word. Okay, so yes, you guys are like doing great. And let's just discuss our last MCQ. And here we are going to stop our workshop for today because a lot of participants wants to join. And as we have problems with the meet, it's only letting 150. So we'll be continuing our, it's a 3 days workshop. Okay,
Dr.
so
Ahmed,
tomorrow
I have a question that why this is the answer is not E, persistent channel
Why?
between aorta. Why the answer is not E?
Okay, so as we discussed that, okay, persistent channel between aorta and pulmonary artery. So can you just tell me that the channel between aorta and pulmonary artery, as we discussed, what's the name of that?
PDA.
PDA, right?
Arteriosus.
Yes, that's PDA. So here, agitated normal saline study is always used for to check whether you have foramen ovale or not, right? So PDA cannot be, right? PDA, like, you know, it's basically a connection. Let me just explain it here. Okay, like for example, okay, let me just explain. Okay, for example, if this is your heart, right? So we know, let's suppose this is your aorta rising from your left ventricle and this is your pulmonary artery. Okay, so PDA is basically connection between your pulmonary artery and your aorta, right? As you inject the agitated normal saline, it's only going to, you know, like move here and show you the studies or show you whether we have certain foramen ovale. It cannot enter like that. And normally we know that the left-sided pressure are more as compared to the right-sided pressure. Even if you're administering the agitated normal saline, so it cannot, like, you know, go in this way in order to give you some bubbles. That's a normal thing, right? You can just think of. So it's basically used to check your present foramen ovale. Is that clear?
Yes, thank you, doctor.
Okay, that's perfect. Okay.
And
So
PDA will close functionally about
yeah, it would
24 hours and
like,
anatomically after 2 weeks.
yes. So like we'll be discussing PDA in details in our further, like basically you need like 100% oxygenation helps in closure of your PDA, except that prostaglandins, like lowering of your prostaglandins, are also helpful for closing your PDA. Okay. So let's discuss our next MCQ. Just give me a second. Okay, our last MCQ for today, and we'll be just continuing our workshop tomorrow. Yes, please. Anyone who want to participate in this MCQ, please raise your hands. Dr. Khadija, can you just please turn on your mic?
Yes.
Okay,
Hello.
that's perfect. Yes, that's perfect. Okay, yes, can you just please read this MCQ for us and try to answer it?
CT scan of the head reveals a left middle cerebral artery stroke. Which of the following physical examination findings is most likely to be present in this patient? Should I read it from the beginning?
Yes.
Yes. 46-year-old man with a 30-pack year smoking history develops right leg pain and
Right
swallowing.
leg pain. He's having a history of smoking. Both of these things so indicate that this, well, okay, he returning from overseas trip. So 2 of the criteria of your Waco triad are satisfied. That is stasis along with, you know, endothelial damage which smoking caused. So it and right leg pain. So it should indicate that yes, this individual is having a DVT, right? Deep vein thrombus.
Yeah.
Okay.
He is diagnosed with a lower extremity deep venous thrombosis and is started on intravenous heparin. Shortly after being hospitalized, he develops right-sided weakness and facial droop. So
Okay.
The answer is D, incomplete fusion of atrial septum, primum, and secundum.
Perfect. So it was basically, we discussed paradoxical emboli, right? And we discussed paradoxical emboli can only, okay, it's also one of your UWorld MCQ. Hope so you enjoyed today's session. A lot of students are waiting for the workshop to join. So tomorrow we are going to start it from the beginning, okay? So tomorrow we'll be having more participants, like, and will we finish? Yes, we'll just finish the entire CVS, okay? Is that clear? I hope so you guys enjoyed. If you guys are interested in our 120 days marathon plan, like we're going to have like same kind of lectures there. You will also introduce you to our other mentors. We also have participants here from our last marathon, Dr. Gayashani. So there are all, Dr. Satarov, they are also participants of our marathon, Dr. Daniela as well. So yes, those who are interested in the marathon, which is going to be starting from 1st May, they should just contact Dr. Hamza for that, okay? Thank you so much, and we'll be completing our entire cardiovascular section. Just get prepared for that. Tomorrow, the timing is going to be same, and the lectures are going to be a little bit long, so please bear me for that. And in the end, you guys must just give your assessment, and based on that assessment, you guys will be providing you the proper certificate for this workshop. Thank you so much. If you guys have any questions, you guys can ask me.
So can you please keep the classes in the evening as we have classes in the morning? We attend college.
Okay, so I'll just discuss that with Dr. Hamza. So he'll be guiding you, okay? Thank you so much. Thank you.
Okay,
Tomorrow
sir.
we are going to discuss everything again, okay? We'll be starting again from our first topic. Just remember that because a lot of participants couldn't join today. Although we are going to provide you the recordings for the session. Yes, we are going to provide recordings on our YouTube channel. We'll just, and there we are also going to update you. So just subscribe to our YouTube channel if you want to get more information about your USMLEs, okay?